Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 497 of our pharmacotherapy series, which majors in acute kidney injury. The next case reads, SJS is a 50-year-old Hispanic woman with a height of 5 feet, 3 inches and a weight of 160 pounds, who exhibited cellulitis 3 days after a car door was closed on her right hand. She was admitted to the hospital, where blood and wound cultures were found to be positive for methicillin-sensitive Staphylococcus aureus. She received 2 full days of nafcillin 2 grams IV every 4 hours before being discharged to complete a 14-day course with dicloxacillin 500 mg orally 4 times daily. 10 days after discharge, SJS returned to the emergency department complaining of malaise, fever, diffuse rash, hematuria, and reduced urine output. The following laboratory values were significant: a BUN of 39 mg per deciliter, a serum creatinine of 2.3 mg per deciliter, a WBC count of 18,500 cells per microliter, with 18% eosinophils. The urinalysis was positive for elevated specific gravity, WBC, RBC, eosinophiluria, and AFE-NA of 3%. So my first question to you is, what objective data suggest drug-induced acute interstitial nephritis? SJS's onset of symptoms suggests antibiotic-induced acute interstitial nephritis. As illustrated by this case, the median onset of penicillin-induced acute interstitial nephritis generally occurs 6 to 10 days after drug exposure. Hallmark symptoms of antibiotic-associated acute interstitial nephritis include fever, macular rash, and malaise. Fever is present in nearly all patients with antibiotic-induced acute interstitial nephritis, and rash occurs in 25% to 50% of patients. In contrast, non-steroidal anti-inflammatory drugs, proton pump inhibitors, and rifampin are less commonly associated with rash, fever, eosinophilia, and the onset of acute interstitial nephritis may occur several weeks to months or longer following drug exposure. SJS's objective laboratory data that suggest acute interstitial nephritis include azotemia, elevated serum creatinine, proteinuria, cellular urinary sediment, eosinophilia, and eosinophiluria. Her FeNA of 3% suggests intrinsic renal disease, and her eosinophiluria and eosinophilia indicate an immune-mediated allergic reaction. Drug-induced acute interstitial nephritis is generally non-oliguric, but oliguria can develop in severe cases of acute interstitial nephritis. The next question reads, how should SJS's penicillin-induced acute interstitial nephritis be treated? The dicloxacillin should be stopped immediately because most patients recover normal kidney function once the offending agent is discontinued. Clindamycin or doxycycline may be chosen to finish the course of treatment for cellulitis. However, SJS has completed 12 out of 14 days of antibiotic therapy and alternate agents would be optional. General supportive measures that maintain fluid and electrolyte balance are necessary. Renal recovery may take weeks to months. Corticosteroids have been used with variable results to shorten the duration of acute kidney injury, but no clinical guidelines have been developed to delineate when to administer them and for how long. Some clinicians prefer to administer prednisone 1 mg per kilogram for 7 days and then gradually taper the dose during the next several weeks. The response to corticosteroids may be delayed or absent in some patients. Dialysis may be needed in patients who are oliguric, but it is usually not required for those who are non-oliguric. The clinician should document SJS's allergic reaction to penicillins in her medical record, and not re-challenge the patient to antibiotics with similar chemical structures because repeated exposure is likely to result in similar reactions. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 498.